senior management of the faculty, our online colleagues, and most of all, Professor Steenkamp. And Professor Steenkamp family, some of them are present today. Very welcome to this event, a very special event in the life of an academic. Today we are here to celebrate the promotion of Professor Steenkamp to full professorship. And for that, I would like us all to give him a round of applause. Gerhard, as we all know him, has become a real stalwart of the faculty. And today we're going to hear how he will develop his field of research, which is dentistry, and take it to the next level. And the next level is going to be very interesting considering what he's already done and what he has achieved. With that, colleagues, I'd like to invite Professor Ferris to do the official welcome and to introduce Professor Steenkamp.
Thank you, Professor Naidu. It is my pleasure to welcome everyone here this evening. Our speaker, Professor Gerhard Steenkamp, the Dean of the Faculty of Veterinary Science, Professor Vinnie Naidu, Professor Miranda Oosthuizen, the Deputy Dean, Professor Amelia Goddard, Head of Department of Companion and Animal Clinical Studies, colleagues in the faculty, colleagues in other faculties, ladies and gentlemen, babies, dogs, and in addition, our colleagues that are joining us online, in particular, Dr. Mark Penning, Vice President, Animal Science and Environment from Disney USA, his supervisor, Professor Martin Bester, for both his MSc and his PhD, and Professor Frank Verstraete, retired Professor of Dentistry and Oral Surgery, and as Professor Steenkamp described, the reason why he decided to go into this field. And then last but definitely not least, Professor Steenkamp's family, his wife, Professor Sonia Boy, and his children, Natanya and Marinus. It gives me great pleasure to welcome you on behalf of the Unit of Veterinary Surgeons for his international contribution to dentistry and maxillofacial surgery for wildlife, in particular, his welfare work on captive elephants. He's married to Sonia, who's an oral pathologist, and they have 2 kids, Natanya and Marinus. Of course, we're an academic, but we're also a human being. And so I wanted to know, well, what do you do in your personal life, in your free time? Can you tell me something interesting? He told me that, well, you know, he enjoys outdoors life, cycling, birding, and traveling. But probably the most interesting bit of travel was when in 1986, when he postponed his BSc studies for a year to spend 9 months on Marion Island as a cat hunter. So he moved from being a cat hunter to being an esteemed professor at this university. Professor Steenkamp, I invite you to deliver your address.
Thank you, Professor Loretta Ferris, Vice Principal, Academic of University of Pretoria, Deans of Faculties, Professor Wynand Steyn, Faculty of Engineering, Built Environment and IT, Professor Vinnie Naidu, Faculty of Veterinary Science, Deputy Deans, Research, Faculty of Veterinary Science, Professor Miranda Oosthuizen, and I also see the Deputy Dean of Medical Faculty here. Very welcome. Heads of departments and directors of institutes at UP. Then there's a host of international guests. I'm humbled by their presence tonight. Faculty, colleagues, and co-workers and staff, many of them here, members of the media, students, my family, And lastly, friends. I would be honest to say this was probably the most daunting talk I've ever had to prepare in my life, because how do I fit 25 years of academia into 45 minutes? It was not very easy. I also have to say I am a surgeon. I'm a clinical scientist. So for those that don't like blood, please, I could not do this presentation in black and white, otherwise I should have or could have. But there will be some slides that maybe don't appeal to everyone's taste. So I thought tonight's lecture I will do in 3 parts. First, give a historical perspective to just show the audience where veterinary dentistry comes from. I will share some highlights out of the journey I've had for 25 years, and then I will take a look at some of the future developments and things that we're hoping will be there for us in the near future. So to delve into the historical perspective, I think equine dentistry is the oldest specialization within veterinary science. Dates back to already 1150 BC. We saw a publication recently that showed an incisor of a skull of a horse that was altered by a stone tool. And further on, 600 BC, also in Mongolia, this is really where the horse was domesticated, Kazakhstan, Mongolia, going into China. There's also evidence of the first horse's skull where a wolf tooth, the first premolar tooth, was extracted. So it's quite a long history that dentistry already has within the veterinary fraternity. And then from 600 BC onwards, we know that the Chinese developed aging structure of horses by using their dentition, not only the replacement of teeth, but also what the teeth and the surfaces look like. So that's been used ever since. We're still using it today. So I've said many occasions we're using ancient techniques. Sometimes we know why. We know horses was used, it really changed our civilization as we know it, because first of all it was used as a mode of transport, then it was also used as a mode of work, these work horses that used to work and plow in the fields, but also carry large weights over far distances. And initially, all of this work, this aging and the dentistry was done by farriers, and later on when veterinarians became trained, which is in the 1800s, that is when veterinarians also started dealing with equine dentistry. Today, horses are still being used as animals that help us make our lives better, especially in more rural communities. But also in the 21st century, the horse has taken up a pivotal place in terms of recreation and sport. This is just out of a publication where they showed the incisor being altered from this archaeological site in Mongolia. So using horses' teeth to age them, as you know now, is as old as veterinary science really, and it's been used over many years. There are pitfalls, but it still is some of the best and usefulness we have for teeth within the equine fraternity today. I'm not going to go into the detail of it, but as you can see from the CT scan on the left-hand side, there is these crowns are fully formed, and that adult teeth in a horse will then carry on erupting throughout its life. And when the tooth finally reaches its end, because of the wear of the teeth, because of the type of diet these animals eat, it will eventually exfoliate, and then the animal doesn't have teeth anymore and ultimately will succumb. So in a horse, this will happen anything from about 25 years onwards, and that's why their longevity is not much more than 30 years. If we look at dogs, dogs only come into the picture around late 19th century, early 20th century. It used to be dentists that at that time had more skills to do more advanced surgery, as you can see here, on these dogs' teeth, because at that time veterinarians did not have a lot of skill in dentistry and were not really part of the fraternity looking after teeth of animals. It also became a model for human research in the 20th century, and that's where the beagle was also born as a laboratory animal, correct size. A lot of studies in terms of the medical field, human medical field, has been done on beagles, and so too are studies looking at dentistry options, models for humans. And then lastly, looking at wildlife. Now, wildlife really became a thing in about 1752 when the first zoo was opened in Schönbrunn in Austria. And that started an array of menageries that royalty started to keep. And as you keep animals, they need attention. And these animals also suffer dental problems. And at that time, they started incorporating a lot of dentists to come and help them. And then again in the 20th century, with laboratory animals starting to take over, we have a lot of primates like chimpanzees, macaques, vervet monkeys, baboons, etc., that came into laboratory animal settings for research, for models to utilize for humans. And all of these animals were kept in unnatural enclosures, and so they needed attention, and they also needed dental attention due to the fact that their diets was also suboptimal. Now, it wasn't until 1976 that veterinary dentistry actually became formally something in veterinary science. Up till then, there was a few people that were dabbling with it, but mostly they were working with dental colleagues, and it was the dentists that did all of the work. So the American Veterinary Dental Society was formed in 1976, and about 11 years later, the Academy of Veterinary Dentistry, which was the forerunner for the American Veterinary Dental College, was formed. And it was only then, once the American Veterinary Dental College was formed in 1987, that students could actually get training for a 3-year program, qualify with a diploma, and then be able to call themselves a specialist in veterinary dentistry. The European counterpart took a little while longer, another 11 years, before it was provisionally recognized by the European Board of Veterinary Specialists, and in 2009 they obtained full recognition. With this, the impetus started to grow, and veterinary dentistry as a speciality really started to take off. So much so that in 2014, at that time, you could specialize in equine and small animals. It was one qualification. In 2014, that was split, and you could then do a qualification either in equine dentistry or in small animal dentistry. This was followed in 2017 by the first fellowship that the American Veterinary Dental College offered, and that was in oral and maxillofacial surgery. In the same year, the American Veterinary Dental College also launched the certificate in zoo and wildlife dentistry, as you've heard in the introduction. So that is the world context. What happened here at OP? Professor Frank Verstraete, who's joining us from California tonight, he was the one that started the clinic in 1981. He was then enrolled in an MEd Vet program, and he had a keen interest in dentistry and maxillofacial surgery, and started the dentistry clinic here at Onderstepoort. At that time, it was only the 3rd one in the world, which I think is something very special. He lectured and he stayed with us until 1994 when he moved to the US. I qualified that year, I moved to the UK, and then in 1998 I returned, and I took over the dental clinic and have been in the clinic ever since. I'm very proud of the fact that we still offer 20 lectures in this undergraduate program, which is far more than many of first world countries offer today, even in these times. We also have a 1-week rotation in the final year program when students come and do clinical rotations with me in the dental clinic. So just to reiterate as well that veterinary dentistry is probably a misnomer for what we do. Because yes, certainly dentistry, as you can see in the scope of practice, is a lot of what we do, but there's a lot more. We do a lot of maxillofacial surgery, like surgical extractions, jaw fractures, temporomandibular joint surgery, orthognathic surgery, cleft palate surgery, salivary gland surgery, oncological surgery, and I can continue. We also do orthodontics, and we also specialize in oral medicine. So the term veterinary dentistry is really not a good terminology for what we do, but I cannot even think of a name that long that will actually show what it is we're doing. We also work with avian patients, not that I've ever seen a hen with teeth, but we can use our materials and our expertise to help these animals that have skew beaks or that have avulsed or fractured beaks to get them back to health again. And then lastly, I'll share some slides where what I've learned in small animal practice and in wildlife practice and how we've been able to use that in aid of conservation in the country. So my journey starts with an elephant, and you will see that my journey is never far away from animals with very long teeth. In 1999, a paper was published in our Journal of Veterinary Dentistry where a colleague, a dentist, then practicing from San Diego Zoo, from the Collier Institute, said that they looked at the pulp of 3 elephant tusks and they could not find any nerves. And this is great news for veterinary dentists because you can work on an elephant's tusk without having to anesthetize it, without having to worry about pain control. And I've ever, since that day and even before, I've lived my life asking the question, why? Why would this be the case? Why is there a tooth that does have a large pulp compared to any other animal, and it's got blood supply, and that blood supply needs control? We need homeostasis within that tooth. And if there's no neural supply to the tooth, how is that achieved? So it just didn't make sense to me at the time. And this started my journey on to doing my master's degree on the elephant. Martin still to this day say that I'm his only student that worked on land-based animals, because all his other work has ever been on marine mammals. So the African elephant pulp is quite voluminous. In my study, I looked at some of the tusks and we measured the pulp, and the largest volume was close to 5 liters. So that is quite a large amount of soft tissue that sits within this tusk. And I then went to the dental faculty and I met Sonia there. Little did I know she would become my wife one day. But this was one of the first papers we published where we took an African elephant tusk's pulp and we could clearly show on the far there you could see the nerve fibers. We showed them close to blood vessels but also distant to blood vessels, which only made sense because that is the normal way that the anatomy would function. And this publication was a year later, was corroborated by other researchers from Austria, where they used electron microscopy as well and also showed the neural fibers all throughout the pulp. Also, as part of my MSc, one of the problems we often sit with African elephants is that they fracture their tusk and you're not sure if the pulp is exposed or not. So I was trying to find a way of using some kind of formula to show that the pulp is exposed or not if you just look at the patient. And we did various measurements of a tusk. You can see up here, I've got a tusk there. That diagonal line, that is the lip line. So if you take a tusk and you look at it, there'll be a very chalky white area until this brown line, and then you will have the smooth tusk that is outside of the lip. So this brown line, this is where the lip will be, and this chalky white area would be where it is within the alveolus or within its socket. So I measured the depth of the pulp, I measured the length to the lip line, I measured the length of the tusks, the circumference at the lip, circumference at the bait, height, etc. Quite a lot of things. And ultimately ended up with this scatter plot that showed there is no way that we can predict how much of a pulp would extend beyond the lip line. So when you go to section a tusk or cut a tusk on an animal that is alive, you always have to remember that you can expose the pulp and therefore be prepared to treat that pulp should that be the case. I continued, because one of the other things I often think about is if we're going to talk about an animal in captivity suffering from some kind of condition, how does that compare to what's happening in the wild? And at that time, a publication by Mikota and her co-workers said that in captivity, 31% of elephants in North America experienced a tusk fracture. So I didn't know how would that compare to what we see. And I got hold of some pictures, some 10,000 of them, of elephants all the way from Amboseli to Addo, and from Damaraland in the west all the way to Mozambique in the east. And you could see that when we plotted the percentage of fractures of those animals compared to the annual rainfall, it was quite clear that the further west in Africa you were, the higher the tusk fractures. And I'm sure most people that have seen pictures or have been to Etosha will know their animals have a lot of fractures. And then as you come to the east, those fractures just about disappear. And I remember in Kruger, there's probably less than 1% of animals with fractures. And I still believe today that the main driver for this is humidity. We know if you take tusks and you store them, they will lose 10% of their weight within the first year unless you keep them humidified. So there was a lot of talk at the time in Etosha that maybe it's fluorosis, maybe that some of the boreholes, the mineral content was too high. But if that is the case, it's a systemic problem, and then all of the teeth should be affected, and all of the animals should be affected. Why only elephant tusks? And if you look at the warthog tusks in Etosha, they're beautiful. So warthogs live underground in burrows, and the humidity obviously is higher there. And therefore, I still believe that tusk fracture, because they're exposed, and in Etosha they congregate around waterholes, there's a lot of animals, they push and shove each other, and that's why chips break off those teeth. So moving on to surgical extractions, which is something that we do. One of the fascinating things about veterinary science is comparative anatomy, comparative pathology. And so it is often quite challenging when you deal with an animal, a different type of animal, the first time. You have to understand the anatomy of those teeth, and you then have to understand how to repel or how to get that tooth out of its socket. And very often there are no tools available, no instruments that you can buy off the shelf, and you have to start thinking and using other equipment that maybe is not always made especially for dental extractions. And you can just look at specialized dentition, something between herbivores and carnivores. Most of you will just think between a dog and a horse. The kind of teeth are just completely different. And then we end up with teeth that continuously grow, like the tusk of an elephant. So how do you do this, and where do you get this equipment? And here I have to thank the engineering faculty, and specifically Dani Berger, who at the time was there. And I was fortunate, before we ended up with this elephant in Poland, I had to extract some smaller elephant tusks, and there was also 2 animals that were euthanized, and we could go and experiment our instrumentation on taking out those tusks. And every time I still do an elephant, I come back and I think there's something else I need, maybe something that can do this or that. So over the 25 years, I've developed quite an armory of instrumentation to work on elephants. But coming back to Nino, he was a young elephant bull. He doesn't look like it here because he was enormous. He was probably in his early teens, and he was already over 5 tons. So it was quite a big boy. He fractured his tusk, and initially I was told they got a dentist in to come and help them. And as the dentist drilled away, the pulp started bleeding. This was just a lot for him to take in, and he just left the animal as it was. Unfortunately, the pulp died, and we had to go and extract this tusk. I say we, Professor Adrian Tordif has been doing a lot of my elephant anesthesia since 2009, and him and I went over to Poland to extract Nino's tusk. Now, when you extract a tusk, one of the things is you want to hollow the tusk out. You want to create a wall of ivory that is as thin as possible. And there did not exist any instrument that can hollow out the tusk. So on this slide, you can see on my sleeve, I carry Somta, who's an engineering company down in Pietermaritzburg. And after years of struggling, I finally happened upon them and explained to them what I wanted, and they just went ahead and made me instrumentation to be able to do this. And I've been using it ever since, and it works brilliantly. So the first step is to hollow out the tusk to get a thinner wall pipe, if you like, as you can. The next step is to use elevators, as you would do in dogs and cats, where you sever the periodontal ligament to loosen this tooth and then be able to extract it out of the alveolus. This is that same setting, but with an elephant. So the bigger the elephant, the thicker the periodontal ligament. It can be about 5-6 millimeters thick. And it gets to the point where if they give me a small hammer and you hit on the elevator, everything bounces back because of the very thick fibrous tissue that is in there. So unfortunately, it looks horrible, but this is the way that you get those elevators into the periodontal ligament space. And this is the key. So you need an elevator that's really strong, but you also need an elevator that can bend, because it has to follow the curvature of the tusk. If you have an instrument that is too rigid, you will drive it in there and it'll go into the tusk. Or if you put it on the ventral surface, it'll go into the skull of the animal. And that you don't want, because that is going to be detrimental to the animal. So this was a case of an elephant that died from the National Zoo. It came to us for a post-mortem, and they asked me to retrieve the tusks for them. And I thought this would be a good time to also take pictures and just show how the instrumentation works and where they need to go. On the far side, you can see this is the table of instrumentation we now have together to take out a tusk. This was last year in Alabama in America, and this instrumentation is steadily growing, the number of what we need to use. Because as we get more and more au fait with what we're doing and get the right equipment, it just makes it much easier. So this elephant we did in Alabama was about 52 centimeters in length, the tusk, and that took us a third of the time as Nino that I will carry on with right now. So Nino, I extracted some pieces of the tusk, and eventually what was left there was so loose I could move it with my hand, but it just would not come out. So what we did was to drill a hole through the piece of remaining tusk, put a piece of steel through there, and put a winch around it. And with gradual traction, we were able to just extract this tooth, literally. And this is the piece that came out. And then once you remove everything from the tusk, from the alveolus, need to go in and remove everything that's remained. So the remaining pulp, maybe pieces of tusk that broke off, anything like that. Now at this time, we've been going at this elephant for about 5.5 hours. It doesn't show it, but I'm rather tired sitting on my haunches like this. And all I'm trying to do is concentrating to get that last piece of whatever is left in there out. And Adrian, that's obviously been working really hard throughout the anesthesia, walks up to me and says, "You should have been a gynecologist." That sort of just broke the tension at that moment. As with any extraction, once you take the tooth out, you want to put all the pieces together, make sure that nothing was left behind, make sure that nothing broke off. And that is what we did here. And this tusk measured at 56 centimeters, which currently is still our record. But from this picture, you can also see the apex. This is where the tusk would be sitting within the alveolus. It's completely deformed. And this is one of the the sad realities of working with elephants is the skull is just too thick. You cannot penetrate with radiographs. So it would have been lovely to know this is what was waiting for me, but you never know that. So even if you go in with an endoscope, sometimes there's tertiary dentine or ivory pearls that forms on the inside, and you cannot get beyond it. So it can become really problematic taking a tusk out if everything is abnormal. So staying with elodont teeth, but just shrinking the patient quite a lot. This is a beaver that also came out of the National Zoo, and he lost his right upper incisor. Now, rodents, the incisors in the bottom jaw and top jaw work against each other. Those are their chisels, that is their tools, how they grind their food down, how they cut through trees to let them fall over, to slow down the rivers so that they can build their houses, etc. So this is an elodont tooth. It grows continuously throughout the animal's life. On the top radiograph, you can see that the root goes all the way to just about where the temporomandibular joints are. So it's not possible to extract this tooth without breaking the jaw. And at the time, a friend of mine, David Crossley, was also over here, and we discussed the problem with this beaver. The tusk is growing out. We have to trim it every 3 months. And he said, well, he knows experimentally you can go in at the apex, so at the root tip of these teeth. You remove the pulp, remove all the tissue, and then it cannot form new tooth. But the tooth will carry on erupting, and it will eventually fall out, and then there won't be a tooth. And we decided to do it. So we went in, removed the pulp, did exactly as it's done experimentally in rats, and 9 months later, it exactly happened as he foretold, and that is the tooth fell out. There was no more problems with this beaver. And as you can see, most of these cases ends up in publication, because I think it's important as we learn, we share this with the world, and hopefully we can use it in some other animals. We're shrinking the patient ever smaller, but staying with elodont teeth, staying with continuously growing teeth. And in South Africa, we have quite a number of people that adopt squirrels for various reasons. And these squirrels often come to us with dental disease. Now, squirrels are some of the animals that are obligate nasal breathers, so they must breathe through their noses. And therefore, if you would get a mass or if something obstructs the nasal passage, these animals will struggle to breathe and they would eventually suffocate and die. So these squirrels presented with poorly formed teeth, continuously elongating teeth, and then when we take a radiograph, we saw these masses. So this is the top skull, would be a skull of a normal squirrel, and the bottom one is one where you can see this mass which is not present in the photo above. And these masses have been first described in prairie dogs, and we looked at it, and again you'll see Sonia's name there. It's the royal we are talking about. And she looked at the histology of these growths, and we term them elodontomas because they come from elodont teeth, and they're hamartomas. They're not tumors in the word that they are malignant. But the problem with these is it's normal tissue, but they're growing haphazardly in an abnormal fashion. And as they ever increase in size, they eventually block the nose. And we've had one patient that passed away because it suffocated to death. So we described all of this. And on these slides, you can see it is not only in the maxillary incisors, but also in the mandibular ones. And I currently have a PhD student that's trying to look into this in much more detail. But this paper I'm very proud of because it's our most cited paper ever, both for her and for me. Coming back to domestic animals, dogs, cats, we do see a lot of jaw fractures. It's the most commonly fractured bone in the body of a dog. And we have a variety of ways to deal with these fractures. But one of the concepts that I was taught as a student and that we still discuss with students is the fact that if a fracture runs in this direction, if this is the nose of the animal and this is the tail, if a fracture in the jaw runs in this direction, all of the masticatory muscles sits around this area at the back there. So when a dog closes its mouth and those muscles contract, if it's running in this direction, it'll lift up the fragment and it'll close this gap. So we call it a stable fracture then. If it runs in the opposite direction and the dog closes its mouth, it'll tear or it'll move the fragments away from each other, and then we say that is not a stable fracture. But then Adrian Kitsov did a study on 109 dogs looking at 135 fractures, and he went and he meticulously drew where all those fractures was that he could. And what was very interesting is those concepts that we were taught, the long oblique fractures, they don't exist on this slide. And what we found is that fractures may start obliquely, but as soon as they get to the alveolus of the tooth, they go straight down, because that acts as a stress riser. So, in fact, most of the fractures that we deal with are unstable fractures. So we don't have to worry about stable and unstable fractures. And also very interesting, maybe it's just because we're a referral clinic, but we saw that the majority of fractures happened around the first molar tooth in the mandible. We know the smaller the dog, the ratio of height of that root to the height of the bone, it gets to 1 to 1. So if you have a small dog like a Yorkshire Terrier and there's some disease, periodontal disease around the tooth, it weakens the bone, the tooth, the root is there, it's virtually the same height as the mandible. So any kind of trauma to that mandible leads to a fracture at that point there. Staying on dogs' mandibles, but moving to the back to where the joint is, we know there's quite a number of conditions that's already been described on the temporomandibular joints in dogs. But one of the problems we sit with as clinicians, it's very difficult to really diagnose disease in the temporomandibular joints. Sometimes on this view you can see there's obvious pathology on that joint, but we know from human studies that sometimes the joints can look horrible, but the patients are fine. They're asymptomatic. So if you sit with a dog that obviously cannot talk, they cannot tell you it's sore in here, you have very cryptic clues that there's maybe something wrong with the temporomandibular joint, and then you don't always know it's the joint. It could be the musculature around the joint that could be at play. So together with some colleagues of mine, we developed a way that we could block those joints, as we do in horses. If we want to see if a horse is lame on a certain leg or a certain area of the leg, we can block those joints and then they go sound and we know that is where the problem is. So what we did was start injecting some of these dogs that we were sure it was the temporomandibular joints that was at fault, and so we put a betamethasone in there with a long-acting local anesthetic drug, and we found that if you inject both those joints, within a day, the clients will phone back and say, yes, the dog is better. So we still don't know what's wrong with the joint, but we at least know that that is where the problem is. And in these, I think it was 11 patients that we did, the average time that they stayed symptom or clinical sign free was 465 days. And this morning I injected a dog that was part of this trial. It is now 3 years since we injected him the first time. So we still don't know what the pathology is, but certainly we improved the welfare of these patients tremendously. Because up till now, the only other option we had was to remove the temporomandibular joint, which is quite dramatic surgery if you're not sure that that is exactly where the problem lies. Changing tack from domestic animals back to wildlife in my PhD, something that fascinated me was the adaptations that cheetahs have on their palates. If you look at lions and tigers and leopards, where their lower molar occludes onto the palate, there's just a dome shape of indentation. Where in cheetahs, they had these longitudinal indentations. And having worked at divulged in Africa, in Namibia, we saw a lot of these animals that had grass seeds or sand or whatever get trapped into those palatal indentations. And then that leads to infection. Ultimately, it can destroy the bone and go over into the nose. And I wanted to understand what the problem was. Why did this happen, and how do we address this? So the first thing I wanted to do was figure out if cheetahs have abnormally large teeth, or how does the size of their teeth compare to that of leopards and lions. And it's obviously very difficult. You can't just measure the teeth and say, oh, this one is bigger than that one, because their body size also differ. So I worked out a tooth index, and what I did was to measure the height of the cusp, the caudal cusp of the first molar tooth in the mandible, and then also at that same site measure the height of the mandible, and dividing the size of tooth by the mandibular height, I got to this tooth index, and then plotted them against each other. And you can see that the leopard and lion are very close, but significantly different from that was the cheetah's teeth. So cheetahs, for the mandibular height of the skull, has got bigger teeth than what lions and leopards have. And one of the theories I have and still hold today is cheetahs suffer from kleptoparasitism. So they will kill prey item, but they have to consume it quickly. They have to gorge themselves. They don't have a pride that can help to guard this prey. They don't have the strength of leopards that can take a carcass up a tree. So they're exposed to whoever's going to smell or hear the noises and come and take the prey away. And therefore, I believe if you have bigger instruments, you can do a more effective job quicker, and maybe this helps them to just eat quicker, get enough food in so that they can move on. And then these adaptations I saw as I was dealing clinically with patients. In this case, I removed the fourth maxillary premolar tooth due to fractures. And if you lift the lip, you can see where the molar sits, and those indentations just correspond beautifully with that. Also, a CT scan of a skull, you can see that the tooth fits into that indentation. And it's a functional indentation. If I remove this mandibular molar, and I've done that in some of the animals, then that indentation disappears. So it's not a structure that's always there. It is there to accommodate that tooth. So in the literature at that time was a condition called focal palatine erosions. And the theory was that the mandibular molars in cheetahs, due to the fact that they don't chew bones, they will start to rotate. The cusp will be higher than what it's supposed to be, and this pushes a hole through the palate. And I don't have the slides here tonight, but I followed 5 cheetah cubs, and there was no rotation of those teeth. It doesn't happen. Specialized dentition, like carnivore dentition, once they're in place, they don't move. In humans, if you extract a tooth, teeth try to fill that gap. The same in herbivores. In carnivores, their teeth don't even touch each other. So it's a specialized dentition that don't undergo rotation, etc. Once they erupted. So we could see in this slide how chicken bones and hair and feathers can get stuck in these palatine crypts. It obviously is uncomfortable for the patient, and left in there, it'll destroy the bone due to inflammation, and then we will get oronasal fistulas. But it was described in the literature at the time that once those teeth rotate, that's it. It's a longitudinal process. It gets worse and it never gets better again. And I had contentions with this. First of all, I thought it was a misnomer, because that is not an erosion. That is an ulceration or worse. So the term erosion didn't fit for us. And the second thing is, this is a very elaborate model that my statistician, Dr. Paul van Staden, who's here tonight, helped develop. And what this shows is we gave a clinical score for how good or bad the inflammation was. And then these were all cheetahs that came to visit, or that I saw multiple times. And you can see all I did was go in, clean out those palatine indentations, rinsed it with water and left it. And we tried on certain of the farms where there was a lot of sand in the diet to try and feed them on areas where they would get out of the sand. So try and rather prevent things going in the mouth than deal with it once it's in the mouth. And what can be seen on these is that it's not a one-way street. Some of them are quite bad. The first time we see it, we clean them. They get better the second time. Some of them will get a little bit worse the next time. So it really is not something that at the time, because it was postulated that the molars are rotating, you need to cut them down. And I did one in my life, and I'm very sad I did. You don't need to do it. Conservative treatment really worked well for these patients, and that is what I advocate today. And I believe it saved a lot of cheetahs from unnecessary dentistry. Sadly, our work takes us to areas where we don't always want to go. And again, I was attending a conference proceeding in the States, and one of my colleagues was describing how he is being used as a specialist when people are suing another person for having a dog that attacked their child, etc. But at the time when Sonia was still at the Faculty of Dentistry, I got to know Professor Herman Bernards, who unfortunately could not attend tonight. And I think he's retired now, but he's still one of the best forensic odontologists there is. And we've been discussing this quite often about how can we write a paper and show how you cannot just say, oh, that's a dog bite wound and that isn't. How do we put science into that and clearly show if it is or is not a dog bite wound? He did his PhD on bite wounds in humans and how they could take impressions from a felon, take impressions from even if it's a deceased body, and all of the deformations and all of those things they worked out to show, yes, it is the person that committed the offense. So I found it interesting when I was preparing for this that there was a paper already in 2002 where it says the dog stands trial for these bite wounds. Professor Bernard said to me, in South African law, and I would think it's most countries' law, a dog cannot commit a felony. No animal can commit a felony. So the whole idea of identifying the felon is not as much in veterinary science what we are after. But he then got a case where a woman was sadly attacked on a small holding outside of Pretoria and she was killed. And they wanted to know both these dogs on the property. Did both of them attack or was it just one of them? And I think most veterinarians would probably sit here and think, well, if it's on the same property and these two dogs live together, I don't think one of them will sit back and say, okay, you go. It's both of them will probably bite. And that is what we had to prove. So Professor Bernards came to my clinic. We got the two dogs in question. The police brought them. We anesthetized them, took the impressions, took all the measurements needed. He went back to the deceased and did his measurements, and we could then show that both dogs actually attacked this person. And this was the seminal report of how we could use dog bite wounds and various things around that to actually determine if an animal actually did the bite work. And I think in the litigious societies we live, it's becoming more and more a case of, but Mr. X, was it your dog that bit? And if it was, they will be sued for not taking good care or controlling their patients. And I had hoped I would never see this again, but I was recently contacted by the police again for another case that they asked my help. Going to conservation, conservation is never pretty. And in 2011, our country got the brunt of rhino poaching, and we really got stuck with animals that was severely traumatized in ways that we could never have even imagined. So it was really difficult when Dr. William Folds from the Eastern Cape called me the first time and said, he's got this patient, she was darted with M99, but she's still alive, and the whole face is hacked open. So really, what can you do? We went there and we go back to basics. I think when we deal with surgery, this is always your saving grace. You go to basics because that's why they're called basics. If you stick to them, you will often be okay. So we had to deal with these patients, we had to deal with the physical wounds, but at the time, we also started a project. I was co-supervisor of Professor M.R. Woyberg's PhD, where we even didn't know basics like the blood values and what was really high, what was really going on with these patients, because some of them, the trauma to the faces looked horrific and they continued to survive. And others had very little trauma, but they never survived. They were dead in 3 days. So although basic science is something that we forget in all of the wonderful things and toys we have these days, in some of the species we work with, this is still very important because we don't know very much about them. So we even went on so far as some of these horns were severely damaged. This is one that was down in Western Cape, where there was abscesses under this horn, and I had to surgically remove this horn. And this is something that I still think today that could be the saving grace for some of our rhinos. If we get a small population of rhinos that just don't have any horns, to just save the genetic material for future. Unfortunately, it currently is not very palatable in society, and therefore we have not moved forward with it. But as part of this whole dealing with these animals, we also wanted to understand what the anatomy of the horn is really like. How is the horn attached to the rhino's skull? And that, again, is where Sonia comes in with her histopathology. And at the time, there was a publication out that said the filaments within the horn was hollow. And that is something that there was a company in South Africa at the time was grabbing onto that and said they're going to infiltrate the horn with a dye and a toxin, and then if the end user buys this horn and they start shaving it off, it's going to be pink. They're going to be horrified that this is now going to intoxicate them, and that will stop them using it. And this is what was published in 2014 by a friend of mine, Sam Ferreira, where they confiscated some horns from a poacher, and these horns came from a nearby farm where this dye was inserted into the horns. And they cut them open, and you can see the dye went nowhere. It just stayed in the hollow that was created. And this is, we believe, if you look at the histology of these, of the keratin in the horn, you have these filaments, and along the sides and the valley, there's the keratinocytes that forms the keratin. So some of them are formed in this direction, and some of them formed in that direction. And this creates an optical illusion. So if you look at them, if you look at a cut section, it looks like there's tubules there, but there are no tubules. And I think that photo by Ferreira et al. Proved our point. So yes, the horn is a solid structure, it's solid keratin, and there's definitely no tubules in it, and we published that paper in 2015. So that's enough of my journey up till now in a few words, but where do we go from here? And I see veterinary science and veterinary dentistry and medical science take hands. I don't see us developing in different directions. I think we're all looking forward to the day that we can start with more targeted therapies, where we know that instead of just using a blanket protocol for certain tumor types, we can actually have a specific treatment for that kind of tumor. And we already started with the melanoma vaccines in dogs. We're going there with osteosarcoma vaccines that's being tested in the US at the moment. And I think the wonderful thing is these are models for human oncology as well. And we haven't really delved into it in this country. Overseas, it's already being used where we can use our patients. Dogs get a lot of osteosarcomas. We did a study in 29 where we showed that it was, together with melanomas, the most common tumor we saw in the dog's jaws. This is just my area of expertise, the oral area. So we do see a lot of them versus in humans where it's not such a common tumor. So there's obviously ways that we can take hands and learn from each other. Patient-specific implants is growing. There's many reasons for that, and I will share some of my experiences with that. Something else that is really going to start taking off more is biomaterials and the development of various biomaterials. We just last week had a discussion with a company that's bringing out materials that work like dental materials, where you can put screws in a bone, you apply this material, and you can set it with a light. So you're not worried about anatomy anymore and having to pre-bend plates and so on. It just fits in there, and it's not toxic to the environment around that implant. So biomaterials, I think that's going to play a major role in future. And then translational medicine. I think working both ways, learning from humans and taking it to animals and vice versa. What we can learn from animals to take it back to human patients. And I'd like to share something with you. So on Friday, we received our first 3D printer, and we're super excited. And there I'm showing the dean who came to visit how we currently have a dog with a huge tumor on his head, and we've just over the weekend printed our first model, life-size model, where we're going to use that in preparation for surgery. Because if you can print a model of what you need to do, there's so much you can do before you go into theater. And you can exercise, you can bend your plates, you can make sure everything is ready, because ultimately that cuts down on the time that you spend within the theater. And the shorter the surgery, the better it is for the patient as well. So the process is you will do a CT scan, especially if bones are involved. You get the scan, that comes usually as a DICOM image, that's the .DICOM at the end of the file. And you have to create an STL file, so a file that the 3D printer can understand. And we're fortunate, we have a fourth-year student that's also has got a master's degree in biomechanical engineering, and she assists us with that between her studies. And then once we have the model in the correct format, we can then tell the printer to print, and it'll print the life-size image for us so that we can do implant development or whatever development we want to do on that. So as a case, I will use Max. Max is a blue and gold macaw that presented 18 months ago. At that time, he already 2 years has lost his rhino theca or upper beak. He was in a fight with another blue and gold macaw, and it just bit it off. So that stump has not grown for the last 2 years by the time they came to us and said, how can we help this macaw? Because now the rhamphotheca, or the lower jaw, is not being trimmed down by the upper beak, and so it's just extending the whole time, and eventually the animal struggles to eat, and then they have to cut it down again. And of course he cannot eat his normal diet because he doesn't have the method to do so. So we started by doing a CT scan, and I did impressions of the rhinotheca, and from that we could establish a stone model. And then based on the CT scan, the developers developed this plastic mold of the beak, and we could take that beak then and fit it onto the stone model, and also we could determine where the screws would fit in to keep this beak in place. Once that was done, and we've tested a few times, it was decided that the best material that we would use for Max was a titanium beak, because it's going to be strong, but it's very light, and therefore they could also color it, because the only request the owner had was he didn't want a silver beak. So this was something that they could, I think, anodize and get him a blue beak, and blue was closer to black, and he was quite happy with that. So not only did they finally print the beak for us, but they also printed some a drill guide, because obviously now you sit with holes on this side and this side of the beak, and you have to line them up, and I'm not that good. So they made these drill guides. It extends on the side. You put the drill in there and you just go straight through. And then SA Spine developed the screws for us so that they don't sit very proud, because if it's going to be in his vision the whole time, it'll irritate him. And we went ahead and placed his beak on him. And this is a video 24 hours later. So obviously the beak is working well. That is soft food, but the lower beak fits nicely within the upper beak. And yeah, it's great to see them eating, but they are macaws, they are naughty. And then you can see he's just looking around what to do next. So this is what we deal with when we deal with patients. We also did similar orthognathic surgery on a chimpanzee, and the whole idea was that he should probably for a good 6 weeks not eat anything hard. And all the keepers were told, and everybody was adhering to this. But chimpanzees live in a group. So the one chimpanzee just tossed him a pineapple within a week, and he was chewing on his pineapple. Fortunately, it worked, but these are the things that we need to keep in mind when dealing with patients. The last patient that I want to just show you is where we use a specific implant. It was a dog that was shot by intruders. There was quite a large defect in the caudal mandible. But also, if you look on the CT images there, you can see that the mandible was actually cracked longitudinally. So if I just take a normal plate, a mandibular plate that we want to use, I cannot get screws in there because the jaw is shattered. So this is a classic example where we can then ask people to model and go and fit a plate for us where we have solid bone, and that is where the screws will go. So ideally, we would want to have screws very close to the fracture site, but here it is impossible. This is what we have, and we needed to do something with it. So again, plate was constructed of titanium. I saw the dog back recently, 18 months later, and the dog is still doing well and is biting hard things, playing with his toys, and this is really heartwarming when that happens. Further to my research, what will the future hold? I think it will always have something to do with long teeth. And here you can see, obviously, the elephants, and I'm interested in how these long teeth gets held in its place. So elephant we've spoken about when Martin and I was in Denmark 4 years ago working on some walrus teeth. They also had narwhal teeth there, and it's fascinating that it looks like a spear. It's such a long instrument these animals have, yet the attachment is only about 20 centimeters. So how does an animal at that speed that they swim, if they get into a fight, how does those teeth not break out of their skulls? What is it that keeps them in place? And similarly so for the walrus, we're hoping to get a paper out this year already, where we're looking at the anchorage of a walrus. And if you think about it, a walrus can weigh 2.5 tons, and yet they can, on an ice floe, grab it with their tusks and pull them out. So the forces on those tusks must be incredible, yet it's only about 15 centimeters of bone that is around each tusk. So there must be something there that we can learn from, that I can take to implantology in dentistry, where we can say maybe in terms of the force per square inch or per square millimeter, how can we take that back and learn from these animals and improve the implants that we have today? I would like to acknowledge a lot of people. 25 years is a long time. There's many people whose shoulders and backs I've climbed on. Professor Ferris, you said, I've reached the top. It's because of those people. And there's many of them here, many of them online, sadly many of them not with us anymore. But I'm not going to read all of them, just some, the veterinarians and faculty colleagues. Out of 25 years, I've never had one person at OP or at the university that I approached for help that said, no, they can't help me. I hope I can do the same. Sister Michelle Kruiwagen in my clinic, she's been with me for 21 years, together with our CSD staff, Samuel and his team. They make sure wherever I go, the instruments are always clean, they're always ready to go. And I've had lots of compliments about that. To Adrian, who's here tonight, and Jose, who was an MSc student of me, who became a real good friend of mine. It's been a pleasure walking this road with you. The University of Pretoria for giving me reins, for letting me go, for letting me fly. I think if I was at any other institution where I had to follow certain research objectives, I may have been found wanting, because this is my passion I'm trying to live. Lastly, my parents, they're not with us anymore. Thank you to them. Finally, I think to my family, these are the people that always carry the brunt. When I travel overseas, it's not with them. This is very seldom when this happens. We love traveling, but it doesn't happen frequently. So to Sonia and the kids, thank you for letting me go and putting up with me not being there. Thank you.
Thank you, Prof. Steenkamp, for an amazing journey or sharing your amazing journey that you've been on. It is truly impressive what you've achieved, and those pictures speak for themselves. I know you promised us blood, but I don't think very many people were expecting that. Of course, we're going to ask the fellow surgeons in the room whether this is bloodless technique that we talk about, or is this just the dentist working with a hammer? I think today we've seen the journey of dentistry, and you've worked the faculty through this. You brought the faculty to the forefront, and we look forward to many more years of you doing this innovative research and bringing through dentistry as a subject field of its own. Because you do create some problems for me. I usually tell people we teach cutting-edge veterinary science. Now I'm going to have to say cutting-edge medicine, cutting-edge surgery, and prehistoric equine dentistry. Colleagues, we've come to the end of today's proceedings. We don't have time for questions, but I'm sure if you have anything to ask, you can approach Prof. Steenkamp either afterwards, if you're here today, or online, and I'm sure he'll be happy to answer. He's always been one of the most approachable persons and vets we know of, and very humble, so I'm sure he'll be very happy to answer that questions. With that, colleagues, we've reached the end, and thank you very much for joining us here in the room and online. Thank you very much. I would ask you to stand while the procession leaves the room.